Hello and welcome. My name is Calah Raab, and this is my DNP presentation. Thank you so much for joining me. Let's jump right in. Over the past decade, healthcare in the United States has seen an uptick in patient acuities and therefore heavier workloads, which has taken a substantial toll on the nursing workforce, with pre-pandemic projections estimating serious concerns of a significant nursing shortage by the year 2030. In the US alone, the Bureau of Labor Statistics, the BLS, projected that the rate of workers older than 65 would increase by 75%, with only a 2% projected increase in growth rates among workers between the ages of 25 to 54 within the decade. As for the registered nursing workforce, the reasons for quitting the profession, aside from age and retirement, include stress, burnout, workplace violence, job dissatisfaction, and family or career priorities. Now, since the pandemic began, the issues already present in the healthcare field have been magnified and exacerbated to dangerous degrees. The increasing demands with diminishing supplies in the nursing workforce before the pandemic are now escalating at alarming speeds, and the result is a progressively stressful work environment for the nurses who remain and the grim reality of an impending staffing crisis much sooner than expected. Based on the increasingly limited resources available to nurses in the acute care setting, and coupled with a truncated time frame, solutions must be created to support the remaining staff while the nursing supply chain can be reinvigorated. If this is not done, the U.S. will face a disastrous shortage of frontline healthcare workers in a time when they are needed the most. The COVID-19 pandemic hit us really hard in 2020, and it threw the healthcare system into a state of flux the likes of which we've never seen before. At the time, this project had not yet been created, and seeing how life was never really going to be the same, and in order to make a project that was meaningful to the nursing community, between March and September of 2020, I cold called and emailed about 40 professional nursing organizations and leaders, and I asked them what their priorities and thoughts were on methods of nursing workforce sustainability, and I asked them about the current status of the nursing workforce, how the pandemic might impact it, and I really wanted to know where they thought the nursing workforce was going. And the main theme from each interaction was nursing stress. Considering how the pandemic was affecting the nursing workforce at that time, nursing stress was at an all-time high and would only get worse as the months passed. I noticed that we have been trying to effectively address nursing stress for many years with different interventions, and yet the issue is still here. Nurses still rank stress as one of the top reasons for leaving their job before the pandemic. So it follows that with these increased levels of stress because of the pandemic, this would likely cause nurses to leave the workforce faster and in greater volume. Coupled with the uncertain socio-political climate with the various legislative changes that were occurring at the time of creating this project, there was much debate as to how these events would affect access to healthcare services through the Affordable Care Act, which would then in turn circle back and impact the already overwhelmed nursing workforce. With the way that COVID-19 upended our policies and procedures, this opened the door to the opportunity to make significant and innovative changes that would not have been feasible during normal times. If we tried to mitigate the stress in a new way, we might find that there is more success in it because we are no longer limited by the barriers of old systems and structures that had hindered us before. One of the ways in which I want to fix nursing stress is to increase the nursing assistant personnel, the NAP, presence on hospital units to better disperse the nurses' workload with a team-like approach to patient care, which is known to improve staff stress levels and the quality of patient care. The NAP is essentially an umbrella term that encompasses the certified and non-certified roles, so you might know it as a CNA, certified nurse assistant, nursing assistant, NA, unlicensed assistive personnel, UAP, and others. And these roles can perform bathing, feeding, dressing, ambulation, transportation, and other types of things for our patients. This is the role we delegate the tasks to that are not part of the nursing process. Now remember, the nursing process is that which involves ADPI, assess, diagnose, plan, implement, and evaluate. Effective RN and NAP teamwork is centered around delegation. Effective teamwork between these two roles prevents missed care, reduces failure to rescue rates, which means that the RN-NAP team is more likely to intervene and catch a decompensating patient before things advance or become irreversible. And teamwork improves job satisfaction because now you're able to practice at the top of your scope and delegate the appropriate tasks to your teammate. So let's go into that a little bit more. Ineffective delegation has the potential for serious ramifications like missed patient care, Oftentimes, there is a toxic environment seen with improper delegation practices due to the friction within the healthcare team from a lack of trust, feelings of resentment, perceptions of the delegator being lazy or incompetent. There are many benefits to effective delegation, including improved staff retention rates because of increased job satisfaction. By being able to retain staff, facilities can reduce the costly process of hiring new staff. Plus, new staff usually don't work with the same efficacy or speed as those who have worked at a particular location for a longer period of time, so there is a lag of productivity initially. Effective delegation improves patient satisfaction and the quality of care, which for the facility means better HCAHPS scores that affects the CMS reimbursements. Consider also the financial effects of proper delegation on the patient, which includes a shorter hospital stay, which means that the patient can return back to his normal life sooner rather than later, lessening the time away from his job, family, and responsibilities. Before I got out there and started to promote this idea, I needed to take a step back and identify where bedside nurses even stood on delegation. And that's what I focused my DNP project on. The ANA, or the American Nurses Association, and National Council of State Boards of Nursing, NCSBN, state that delegation is a fundamental nursing skill and must be mastered in order to provide adequate and proper care. This project aimed to reinforce this stance by evaluating where acute care nurses currently are with the delegation and NAP role in terms of attitudes and knowledge, educate and increase awareness of delegation and its benefits and ramifications in the nursing community, and encourage discussions on how delegation can effectively support the nursing workforce in the upcoming years, assess the efficacy of the educational intervention, and provide a foundation for future research to build from on this topic. This project was created based on the relevant literature to observe a change in self-reported attitudes and preparedness with delegation. This approach aimed to identify whether acute care nurses are not only confident, but also competent in their delegation skills with NAPs. The expectation was that this project would demonstrate that the educational intervention improved nurses' attitudes and knowledge on delegation practices, as evidenced by improved levels of empowerment and confidence in the study, thereby supporting an increase to the utilization of NAPs in the acute care setting. A long-term goal was to establish evidence for future research to investigate the foundation for a novel approach to reducing nursing stress by increasing the number of NAPs present in the acute care setting. And the expectation was that this project would demonstrate that this educational intervention was effective in improving the knowledge on delegation practices among nurses, and then that would therefore take us to the next step in supporting the idea of increasing NAPs in the acute care setting. Out of 493 initial articles dated between 2000 and 2021, I pared down my results to 18 well-regarded articles after an extensive critical appraisal. Despite delegation's demonstrable importance, not many acute care nurses effectively delegate. It comes down to how nurses delegate, if they delegate at all. For reasons like poor communication, which impacts teamwork, and feelings of trust for the other members of the healthcare team, which is heavily influenced by nursing leadership's involvement, scope of practice uncertainty, where the RN and NAP don't fully understand how and where their scopes of practice interrelate, and an overall lack of standardized knowledge on the proper aspects of delegation, leading to misunderstandings and missed opportunities to delegate. Previous recommendations and attempts to improve nursing delegation skills and the overall implementation of delegation in the acute care setting included task forces, delegation simulations for RN and NAPs, additional time in the RN's transition to practice phase with increased exposure and interaction with NAPs, the development and implementation of teamwork-based nursing care models that involve the NAP role, nursing leaders instituting methods to empower staff and creating a nurturing environment so that more delegation and effective communication and really teamwork is possible, and regularly scheduled educational workshops. I collaborated with the American Nurses Association of California, the ANAC, and Nurse.org to reach out to acute care nurses across the state of California. The online study had a quantitative cross-sectional design where participants were obtained through convenience sampling. The data collection period was between March 1st and May 3rd, 2021, and the study was active and available 24/7. During that time, participants were able to click on the provided link embedded in the various outreach methods, which I'll go into shortly, and they would be directed to my study on the Qualtrics website. There they would be presented with the consent and then taken into the inclusion and exclusion criteria. What I was looking for was basically that the participant had to be an acute care RN with an active California RN license, currently working at a hospital in California on an inpatient unit. They had to be older than 18, They had to have been working for more than 6 months at that current hospital and more than 6 months in the acute care setting. They had to be full-time, and they had to be on a unit that employs nursing assistants and that also utilized the nurse-to-patient ratios of 1 to 3, 1 to 4, 1 to 5, 1 to 6, or 1 to 8. So basically, no critical care, no perioperative, and no emergency departments. Initially, I was only targeting ANAC members. Once my amendment was approved to increase participation rates, I opened the study up to everybody else. If a participant qualified, the software would then lead them to the pre-survey, then the video, then the post-survey, and then they'd be directed to complete an optional program evaluation and or just retrieve their free CEU as provided by the ANAC. The pre-survey consisted of 2 tools, while the post-survey only had 1, and that was meant to capture and compare the magnitude and direction or the relationship between the participants' responses after having viewed the educational video. The reason why only one of these 2 tools was repeated was because its questions were aimed at evaluating participants' knowledge, while the other tool was better at assessing participants' feelings, and I wanted to capture a change in knowledge. The data was analyzed using the non-parametric Wilcoxon rank test since the project contained 2 dependent groups with ordinal data and a sample size of greater than 5 pairs of measurements. I had 20. The aim was to observe a positive change between the pre- and post-survey responses. This change would then indicate that the intervention was effective. The 2 instruments used in this study are not accessible through the public domain and were found through extensive research in the EBSCO database library. The first tool, originally a self-assessment, was created by Mr. Theodore Crane, then modified by Kiernested and Braga.Tisch for their 2012 study, and then by me for grammar and the anticipated redundancy of certain questions when combined with the second instrument by Thomas.Tesch and Gers.Tesch. For expert evaluation, the consensus was that the tool's meaning was not affected in the modified version. I used Crane's tool to capture participants' feelings or attitudes toward delegation and the nurse assistant role, and the Icelandic tool to evaluate participants' knowledge and whether there was a change in their answers between the pre- and post-survey. Both tools utilized Likert scales with answers ranging from always to never or agree to disagree. Here are a few examples of the outreach methods that the ANAC and nurse.org used. Starting March 1, 2021, the study was live for participation and displayed on the ANAC's campaign page, Twitter, LinkedIn, Facebook, Instagram, e-newsletters, and in emails. Only ANAC members were eligible to participate at this point. Around the 3rd week of data collection, the response rates had significantly dropped, so an amendment was submitted to include nurse.org's collaboration to increase outreach methods to advertise the study on their blog, podcast, YouTube channel, Instagram, and Facebook. The study then closed on March 3, 2021, once enough responses were collected, which ended up being 30 total qualified responses. Here are my participants' demographics. Of the 30 participants, most were female, most were between the ages of 31 to 39 years old, and most identified as white, with Asian as the second largest group. While the study was sent to acute care nurses across the state of California, most of the eligible responses came from Los Angeles County. Of the 30 participants, most reported being active members of the ANAC. Now, what's not shown here is that when participants were asked if they had taken a leadership course or leadership training within the past 2 years, over half indicated yes, over half of them held bachelor's degrees, and over half of the participants stated that they had been working as a registered nurse between 1 to 5 years, with the second largest group having worked between 6 to 10 years. Many participants reported working on a medical surgical unit. Of the 30 participants, most of them indicated that they worked in a unionized hospital. Now, what's not shown here is that most of the participants worked on the day shift, and most participants said that their primary unit's nurse-to-patient ratios were 1 to 4. Of the 20 matched pairs, these 5 were statistically significant. The Wilcoxon rank sum test can be used to test the null hypothesis that there is no difference between the pre- and post-survey responses. As seen here, the data demonstrates low variability, as evidenced by the low standard deviations, indicating consistent responses between the pre- and post-survey. Pair 14 had the largest standard deviation, which, as we'll see in a few slides, had the most change between the pre- and post answers. The purpose of a Wilcoxon signed ranks test is to determine whether there is a difference between the means of 2 related groups, or in this case, the pre- and post-study results from the same group of participants. Next, I'll show you what that looks like. Do you give staff feedback following delegation, like praise? In this pair, 9 people felt more confident that they give staff feedback following delegation to their NAPs, so we see that reflected in 9 post-survey answers moving positively towards either agree or always. We can see that one person even moved their answer 3 ranks in the positive direction. They could have felt very strongly when reinforced with the intervention's content. 19 participants felt the same regardless of watching the video. In delegation, do you make clear where to do the task? In the 10th matched pair, more participants felt the same between the pre and post survey about clarifying the location of a delegated task to an NAP. 7 people answered positively, likely indicating that they realized after the intervention that they do explain where the delegated task was to be done properly. This suggests that with improved understanding about the components of delegation, participants realize that they do communicate one of the fundamental components of delegatory instructions, and that can foster one's self-confidence. Both the 2nd and 10th matched pairs demonstrate significant movement in the positive direction between the pre and post survey, indicating that the educational intervention was effective in sharing the necessary information to participants. Rules regarding documentation and the use of nursing diagnosis have made me delegate more than before. The most movement was seen with the 14th matched pair. There was a significant change in rank and number of participants, demonstrating that they felt much stronger in the post-survey about the rules of documentation and nursing diagnoses imposing effects on the role of a delegator, with an individual change as high as 5 ranks in the positive direction. This could represent the increased awareness of the intricacies of proper delegation and how it factors into the nursing role. Nearly an equal amount of people felt the same between their responses before and after the intervention. I think I have sufficient skills to face staff's negative reactions when delegating tasks. In the 19th matched pair, 11 participants felt more confident about their ability to face criticism when delegating after the intervention. This could represent a boost in participants' confidence levels after an educational refresher. Most respondents did not feel a change in their ability to face negative reactions. I am familiar with my legal responsibilities when delegating. In the 20th matched pair, most respondents felt surer of their knowledge about the legal aspects of delegation after the intervention than before, with as much movement as 3 ranks upward in the positive direction. This was the only pair to have a majority of participants shift positively in the post-survey, suggesting that the intervention was successful in educating the participants on the legal ramifications of proper and improper delegation. The greatest lesson that this study offers is insight into how the characteristics of unit staffing directly affects the well-being of both patients and staff. By recognizing the study's implications, protocols can be created to establish standardized NAP staffing ratios, like how California has created RN to patient staffing ratios. Same idea. More research is therefore warranted to determine these numbers for each acute care specialty's needs and the NAP role. Additionally, there must be clearly defined scopes of practice for the NAP role within California's NPA, the Nursing Practice Act, because as it stands right now, the verbiage leaves much to interpretation, and that just perpetuates one of the main barriers to proper and effective delegation. As for future research, to competently recommend the idea for increased NAP presence on acute care units, more insight is needed from nursing leaders, unit managers, charge nurses, CNOs, and others who are involved in the hiring and staffing decision process to gain a comprehensive understanding from all perspectives and motivations. This scholarly project has the potential to create substantial changes in the policies and procedures that govern nurse staffing and ultimately patient outcomes. Nursing leaders are identified as crucial factors that can create and allow for proper delegation practices through the establishment of a therapeutic environment that promotes communication and the provision of the necessary tools for nurses to operate autonomously, which promotes empowerment. This project also highlights the importance of including bedside nurses in getting involved with professional organizations and taking part in decision-making opportunities. The ways in which the healthcare field can benefit from this project are numerous and include overall reduced costs by means of reduced HAPUs and other hospital-acquired complications, thereby increasing reimbursement rates, reducing the number of supplies used, shortening the duration of hospital stays, lessening the nursing stress levels while boosting feelings of satisfaction, empowerment, and just general well-being and mental health. And those in turn improve staffing retention rates, which reduces the major costs and time associated with new hires and enhances the delivery of higher quality care and staff working at the top of their scopes of practice because of increased staff availability, which thereby lowers incidences of missed care or failure to rescue rates while preventing additional legal actions. The study's findings are supported by the literature. The methodology demonstrates efficacy and feasibility for larger scale implementation, and the educational intervention achieved the stated goals. Additionally, this study demonstrates the benefits of cross-collaboration between professional nursing organizations to work together to achieve the same goals, Lastly, this study highlighted how bedside nurses can get involved with their local or state or national nursing organizations to help make a change. The SARS-CoV-2 pandemic presented to be the largest barrier to overcome as it prevented student access to hospitals, therefore eliminating any opportunity of direct bedside nurse interaction and participation for data collection. So the study was designed with a flexible methodology in the form of an online survey. Now, that survey was sent out to the nursing workforce at the same time as many other professional nursing organizations were investigating the feelings and experiences of the same population while working through a novel pandemic. Now, the nursing workforce was facing unprecedented stressors in their workplace and personal lives on top of survey fatigue. So, with the addition of another online survey, that likely added to the survey fatigue and overall burden. The study was lengthy because it offered a free CEU upon completion, so the educational video had to be at least 60 minutes long in order to qualify for the California BRN's guidelines for CEU providers, and the participant was also to complete the study in one sitting, which therefore both of those aspects likely limited the volume of qualified and completed responses. The study was initially targeted to the members of the ANAC, and since the majority of qualified responses were obtained before the amendment phase, this accounted for nearly 100% of the responses, likely affecting the data interpretation since this population of nurses tends to be more involved in leadership roles or activities. This study only looked at acute care nurses in California, which is the only state to have enforced nurse-to-patient staffing ratios. This project was presented to over 100 nursing leaders and administration during a monthly interdisciplinary nursing grand rounds on Zoom for City of Hope on November 16, 2021. A poster presentation was created for ACNL's in-person 44th annual conference between February 6 and 9, 2022 at the Disneyland Hotel and Convention Center in Anaheim, California. An interview with ACNL also occurred on the project's topic for their podcast titled ACNL in Action, Lessons in Nursing Leadership, and for their social media on March 29, 2022. I fully intend on continuing to interview, present, and discuss this topic as much as I can, and I will also be submitting my research to journals for publication. The novel SARS-CoV-2 pandemic will continue to drastically impact how the U.S.'s healthcare system functions, and more than ever, costs will be driving decisions for the foreseeable future. Therefore, this study sets forth a foundation that introduces a long-term solution to achieve both improved patient outcomes and the welfare of staff during times of increased demand and reduced supply. Not only can this approach be applied to the most current example, a novel pandemic, but also during other times of high demands, such as the annual influenza spikes. In 2020, the BLS projected that NAP job growth between the years of 2018 to 2028 would be 9%, while the RNs would grow at a 12% rate, which is essentially a 2-to-1 ratio. This is imbalanced when costs are taken into consideration because the NAP role gets paid at about $30,000 a year, which is about half that which the RN gets, which is about $75,000 a year in California. Considering the value of the NAP role and how much they cost, this role should be growing twice as fast in order to accommodate for the drop in available RNs. Taking into account how quickly the training is for the NAP role in comparison with the requirements to become an RN, it is feasible to flood the healthcare market with new NAPs and better utilize those who are already in the healthcare workforce. So firstly, there should be a push to train and hire more NAPs and bring them into the acute care setting. And secondly, acute care units should establish staffing ratios for NAPs to better meet the elevated workloads that RNs face during times of increased demand. By applying staffing ratios for NAPs, the nursing workforce can be better supported for the long term. This will not only improve patient care, but it will help reduce nursing stress, burnout, and the associated detrimental feelings that lead to increased attrition rates. The success of these proposals and achieving the desired outcomes is contingent upon the quality of the interactions between RNs and NAPs, which is rooted in proper delegation practices and the influence of nursing leadership. Routine educational courses to rejuvenate knowledge and familiarity are therefore key. These recommendations are feasible and have a significant potential in revolutionizing how the healthcare field staffs hospitals. It is important that nurses are cared for, or else there will be no one left to care for the patients. With determination, perseverance, and the incorporation of innovative ideas like what this study presents, the future of nursing is bright. Thank you for listening. Here are my references.